the question of, how come we can't accomplish this simple transmission of data to where it needs to go? And I want to provide through some examples and try to dig in a little bit at the information level as to why these problems occur. Why doesn't this occur in other industries? Why is healthcare so far behind in these things? So through some examples, through some diagrams, I'd like to be able to convey some of the issues, where the problems are, where we're moving into solving some of these problems, and that will kind of provide a basis, a framework from which then Steve is going to be presenting on the front end. What does the user see? How is that data coming in while we're looking at some of the technology, and how key that data is to providing that technology. To show an image without the appropriate associated data flowing through the system, you can't do anything with that. So it's very important that that underlying framework, that underlying connectivity and integration is a critical component with any information system and any information system flow. Now, just a quick outline. I'm going to start at the 50,000-foot level, talk about the electronic health record, and then a bit about a strategy of attaining or working towards or progressing towards that. Then I'm going to dive right into radiology and talk about a case study and talk about some of the work that we've done in order to get integration as that basis for which we could improve the workflow in the department. Talk about some of the initiatives that are out there in the industry. Go through a step-by-step diagram on workflow to give you an idea of all the components and all the pieces and how they interact together. And then talk about some of the regional initiatives that are very extremely important, but also tend to be the norm today. Regional systems in the U.S., they call them integrated delivery networks. A region, even just take KW, where you've got the 3 hospitals. Right now, they all operate independently. What does it take to move them to an industry initiative where that information transfer can occur across the region, link into sites like London Health Sciences, and be able to start to share information about a patient no matter where the patient goes. And then lastly, Steve's then going to follow up and provide some diagrams, or not diagrams, but actual demonstrations on some of the technologies that we've developed. Okay, very quickly at the 50,000-foot level. An integrated delivery network or a regional system is not just within the 4 walls of the hospital. It's across the community. It involves the family physicians, the nursing, home care, outpatient centers, et cetera, et cetera. There are a lot of stakeholders in the region that are part of the solution. And they all need to communicate with each other. I would call the electronic medical record, or the electronic health record, really a holy grail of medical information management. And we're a long way off from being able to accomplish what we think we can easily accomplish, and I'll give you some glimpses as to why. Really what we want is a patient-centric approach to healthcare. We want to be able to start at the patient, and regardless of where their care is, to access information about them. But some of today's challenges, specifically within the hospital environment, it's an encounter-centric, a departmental approach to information. So each department has their own information system. They don't necessarily share with other departments. If they do, they don't share outside the boundaries of their facilities. So now you've got a bunch of your patient records scattered around a region, and there's no way to cross-feed that information. And many of these systems are disparate islands of information. They may not be able even to communicate, and that's both within the hospital and across this region. Now, one other piece that's critical, if we were to take our region and connect everything together, every system has their own master patient index, their own patient identifier that's local to their own system. So when you start to share information, how do you know that patient 123 at this facility is the same patient as 456 at this facility? How do you link that information together? One way is through an enterprise master patient index. And I would say this is one of the cornerstones of the electronic health record, being able to at least link those patients together, link them across the disparate systems. But many regions have a tough time implementing these things because there's a lot of work that needs to be done. They require thorough analysis between the various facilities and determining patterns of names and how to resolve these things, and to go through that whole registration process, the remediation process, and cleaning up what data is already out there. You can't just start fresh. And lastly, once you've done all that cleanup, you've got to be able to embed into the processes moving forward so that you can maintain that as an ongoing process. So an MPI, although you can buy MPI products, it's more about process than it is about software. Just as a cross-functional or a cross-sectional view of the enterprise, information would tend to flow up and down these layers. And really, this should probably be drawn in more of a V because the complexity, as you move up these layers, tends to increase significantly. So you have your acquisition devices, whether it's in labs, you've got the blood work, doing the blood work, whether it's in ophthalmology, you've got the microscopes, or if it's in radiology, you've got the CAT scanners, the MRI machines, and such. That's where the sources of the information are. And that information has to pass through and be collected and managed by the information systems at the department level. And typically, information systems at the department level tend to be inputs of data, not necessarily designed for outputs. So by being kind of sinks for data, they were never designed to be cross-clinical reporting systems for what is needed at the enterprise level. So they tend to be great for local reporting, departmental reporting. The radiology system will have its own reporting. Lab system will have its own reporting. But up here, with the enterprise users who are out across the enterprise, they need a bit of laboratory information. They need a bit of radiology information. They need a patient-centric perspective on all the stuff that occurs down in the department and the tests that are performed on that particular patient. Now, how do we map the ideal of what we want into something that's real? Because the users at the enterprise level, all they want to do is just have kind of like the internet. You get on a web browser, you take a look in, you don't know where the information's coming from, nor do you care, as long as you get the information. And so here's some of the things you've got to deal with. You've got to deal with, well, the business systems and the clinical systems. There has to be some cross-connection there. You're dealing with multiple facilities, multiple hospitals and the family physicians, the home care. All those systems have to come together somehow. So there's a lot of times best of breed. No one vendor has a system that's complete that can solve all these problems. You've got multi-vendors to deal with, different ways of setting up their systems. You've got to conform them somehow and extract the appropriate data elements so that you can make use of them at the enterprise level. And there's still legacy systems out there, systems that are so closed that you can't even get information out of them to pass on to other systems. Standards are continuing to evolve. They will continue to evolve even more so, and new standards are coming up as far as how to communicate that information. And how do you define then a growth path so that you don't get locked into a situation or a solution today, but can map a strategy for the future? So there needs to be a framework, a way to say, okay, I've got all this mishmash of information in all these various systems. How can I overlay something where I can start to extract this data? I can work at a very detailed level on the integration side and in some cases duct tape the systems together so I can get information out and collect it, make sense of it, summarize it, and present it up to the user so that it makes sense. And this is not an easy problem. This is an extremely difficult problem. This makes it look easy, and almost too easy. But there's a lot of stuff underneath that needs to happen in order for these individual departments even to push their information up and manage it and bring it together so that it actually makes sense to the various types of users at the enterprise level. Okay, so that's enough of the 50,000-foot level. I just wanted to provide a bit of background, kind of a summary of some of the discussions we had in these sessions last year. And I want to get down to more of a practical aspect of this and talk about radiology and PACS as it's been introduced into the radiology department over the past number of years. Radiology has always been pretty well at the forefront of innovation. They've kind of, in a lot of hospitals, including the one I came from, kind of been on their own, doing their own thing, because the IT department, which I came from, didn't understand really what the fuss was all about in terms of transferring information. We're used to dealing with a couple of kilobytes of information. We had no concept of dealing with megabytes and gigabytes of information. That was just beyond our thinking. But radiology was always a little technically savvy. They were dealing with imaging modalities. They always had the good toys. Always had a lot of fun linking all their toys together. Toys that actually did something. So, now the IT requirements of radiology tended to kind of push here, but it's really pulling IT along because IT really didn't understand the bigger picture of the impact that PACS would have on the enterprise. And so technically more challenging, I mentioned moving megabytes, gigabytes, and even terabytes around. Connectivity requirements between the HIS, the Hospital Information System, the Radiology Information System, as we call the RIS, the modalities themselves, the PACS itself. All these components have to come together in terms of a workflow. And then, well, that's just one facility. Then you multiply that into a regional perspective, and you've just multiplied the complexity now in terms of trying to bring all this together and dealing with those patient identifiers. And distributing that data, because really radiology is just, I call it, and I don't want to, hope there's no radiologists here, I call it kind of the factory, because there's inputs from the enterprise, the request for the exams to be done, radiology department does the exams, produces a report, and pushes it back up into the enterprise, back to the referring physicians, to the clinicians and specialists who need that information to work with their patients. Because radiology has been kind of at the forefront of innovation, it provided a natural starting point to start thinking the big picture, thinking across the enterprise. It's not a departmental system, it's an enterprise system. So, okay, what does that mean? What does that imply? When we start thinking enterprise, we need to push images out to the PACS and to the enterprise. What does that entail? Well, right away, we get into master patient index, we get into portals that are easily accessible, that you can easily pull up images and view the images, grab the reports, link into a lab system for a reference to a lab exam, etc. And very quickly, we're pushing into the electronic health record. Now, I've got electronic patient record here. There's kind of two levels. The electronic health record is really your longitudinal record, the cradle to grave idea. Let's stay in the confines of the hospital here for the purpose of these demonstrations. The electronic patient record is a collection of the heterogeneous amounts of information that are needed and bringing them together so they're under a patient-centric view. Okay? Now, the key to bringing information up at the enterprise level is making sure that you've got your workflow properly managed at the department level. If you can't get the data out, you can't get the information at the enterprise level. So you need to make sure that we maximize the workflow within the department in order to achieve that. So let's kind of slice underneath here, because it's obvious you need some information systems which are the cornerstone to each of those departments. So in radiology, you depend on the HIS for the patient identifiers. You need the RIS to manage the scheduling of exams, the creating of reports and stuff in the RIS. You need the PACS to manage the imaging side, and a lot of those systems are starting to come together into a complete departmental system. But to make it all work, you need connectivity, you need integration. And it is a key critical success factor in any PACS project, and I've seen PACS projects fail because of one of those pieces not in place on the integration side. This is not probably so true anymore. In the earlier days of PACS, the last thing thought about was how do these systems connect. And part of it was there was just an assumption that, oh, it's HL7 in terms of a protocol for pushing information around, no problem. Little did they realize that HL7 to one vendor was implemented differently than HL7 with another vendor, and just because they spoke HL7, they didn't exactly communicate the first time, so that required a little bit of work. Then there's the expectation that the systems will just connect anyway, because aren't they supposed to? And then there's the expectation that vendors can do the connectivity, because, well, that's their business. Don't they think about the rest of the hospital, or do they think of just their own system? And without integration, there's a number of things. You've got multiple points of data entry. You've got no quality control on the information. and you have no way of ensuring that data is entered only once and passed through the system. It's very easy to transpose 2 digits when you're entering a patient identifier. So these sort of things without integration are going to be problematic when you're trying to bring all the systems together. Sorry, I'll address questions just at the end of this. Thanks. So integration improves workflow, but what kind of integration pieces are there? There's front-end integration. That means that when you're in one application and you want to hook into another application, that you want to hook into it from the context that you've already provided in this application. You don't want to log into this application, log into that application, go through all the search mechanisms multiple times. You want to be able to link into another application and jump right back to where you were before so that your workflow is maximized. And that's primarily called desktop integration. And then on the back end, there's interface engines, there's workflow managers, which basically are a smarter type of interface engine. Interface engines, I call them just dumb routers. They say, okay, route this to here, here, and here. There's not a lot of brains in it. Workflow managers take into account the workflow in a particular department and maximize that between all the different components. And then once you've got all those pieces, well, then there's access into an electronic patient record, hooks into the enterprise so that you can actually distribute that data into the proper web portals and such. Okay. There are some industry initiatives, particularly started in radiology and starting to move now into cardiology and with a goal to move into labs and other departments as well. But it started in radiology. It's called IHE, Integrating the Healthcare Enterprise. And it's an industry-wide initiative with multiple vendors coming together and collaborating and saying, okay, we have some standards that are in the field today. On the information side, it's called HL7. On the imaging side, it's called DICOM. Now, there are different ways of using it, but why don't we come together and agree on one way of implementing so that everybody who conforms to IHE, all those systems, we can guarantee the user that they're going to connect fairly cleanly because they've complied to this framework, this integration framework. And the purpose of IHE was really to integrate these processes between these imaging and information systems to promote an open systems environment so that you didn't get locked into a single solution without an opportunity to evolve. Utilize existing standards, not create new ones, but utilize existing standards. Now, that can be extended to also utilizing standards as they come available or as new standards are defined. And of course, we want to continue to evolve, but by following this model, it would allow for that to happen. Demonstrate the interoperability between systems, but not just demonstrate. Because anybody can demonstrate in a lab environment, but it was actually fostering the usage in actual commercial products. And it's at a point now where hospitals are creating their RFPs for PACS systems and including IHE functionality or components in it. They want to see that in the product so that they can maximize that integration, which again just shows you how important it is for those systems to integrate. Now, what if some vendors don't want to comply or aren't part of that? What happens? Not to pick on any particular vendor, but there are vendors that don't participate in it. And Meditech, for instance, installed in more than 50% of Canadian hospitals. So while this initiative is going on, we still got to deal with the real world. We still got to deal with a bunch of heterogeneous systems that need to connect. And while there are great initiatives out there to ensure that or to at least move down that road, there are also equally as many cases where that may not be the case. All right. I'd like to just change gears very quickly here and just walk through a departmental workflow. There are probably different ways of doing this workflow, but I've just provided one. This will set up Steve in terms of the various components in a radiology department and how the information flow goes through. And then Steve will indicate some of that information flow when he does his presentation or demonstration. So I'm going to just walk through a patient registration, go through the order placement process, go into the departmental filling of that order, providing the work list at a particular imaging device, and storing those images, doing the diagnostic reporting on those images, distributing that information out to the web, and I've added one more, which is more of an EPR type integration that is linking into an external electronic patient record. Okay, I'm going to run through this fairly quickly. a patient's registered in health records. Could be an outpatient, inpatient, emergency patient, any sort of thing like that. That information is communicated to the various subsystems by means of usually an HL7 protocol, but we won't get into the details of the protocols, but just understand that when the ADT system, the health record system, gets information about a patient, that information is distributed to radiology, labs, pharmacy, all the various subsystems. And from a PACS side, I've drawn this workflow manager in the middle to manage data coming in, which might be in one form, to data going out, which might be in another form, but that conversion process and that workflow management is all contained within this component here. Okay, secondly now, a patient's registered and we need to order an exam. So somebody's going to say, I need a chest x-ray for this patient, and submit it into the radiology department. The radiology department is going to fill that order by providing resources to do the exam, provide a particular imaging modality on which they're going to take that exam, provide a date and a time, and all the things that are needed to fill that order. This is the point where the workflow on the PACS side starts to take place. So the PACS is going to receive that order, and there's a bunch of things that happen. The PACS itself, the image manager portion of it, receives that and says, okay, Mr. Smith's coming in for a chest x-ray. Well, I've got some other chest x-rays that he's had over the past couple of months, and I'm going to prefetch that information off of the archive and make that available to the radiologist. So when the patient has this exam done, the radiologist can pull up the old studies, pull up today's study, and make a comparison on any changes that have occurred in that chest x-ray. And then that physician or that radiologist is going to create a report. So that's what the prefetching method is all about. Now, the patient's registered, the exam has been scheduled, the patient arrives in the department and arrives at the imaging modality, the x-ray machine. And the tech now is at the x-ray machine and presses a button, depends on how the modality is set up, but refreshes the work list. How does it get that work list? It goes back through the workflow manager into the RIS information, into the RIS, and this will depend on which RIS in terms of how the workflow goes, because most RISs actually just push information out. They don't actually respond to queries. So the workflow manager is then collecting some of this information in a cache, and the modality says, okay, I need my work list for today, and I'm this particular modality. So the work list gets passed off to the tech sees the display, selects the patient who's waiting there, and voila, all that happens automatically. That data is collected and connected to the images that have been acquired, and the next step then, there is information from that exam that can go back to the RIS and auto-completing of the exam. Because what happens, the tech's going to go and do the exam, moves over to the radiology terminal and says, I've completed the exam. 2 manual steps. Why not have a message go back from the modality back to the RIS that says, hey, this exam's complete. I don't need to enter this information. It's just automatic. That's what this particular message does. Okay, the images have been acquired. Now we have to send them off to the PACS archive. And there's some processes here that allow for that to happen. The modality says, I've acquired so many images, passes them off to the PACS and says, did you receive that exact number of images I sent? PACS says yes. The modality deletes them, and now the PACS has those for storage. And in many cases, the PACS is going to say, okay, I need to push these out to an enterprise web server so that these images are also available via an intranet web access. So it's going to route them off to there as well. And there could be other places those images are routed as well. Okay, now the radiologist, the images are ready. The radiologist has a work list that says these are the exams I have to create reports for. It's going to do the diagnostic reporting. Part of that diagnostic reporting is performing dictation. If there's a digital dictation system, creates the report gets converted to text, and the RIS needs to receive that text because the RIS traditionally is the final repository for those reports. So that whole process occurs, and that's basically it as far as the workflow. Now we're at the enterprise level, and an enterprise user logs into the system. sees a list of patients, wants to take a look at the images, it'll go now to the web server because these are stored in a different format than they are here, and is able to then, via a web browser, access that information easily. And the report is typically queried through the workflow manager again to view along with that. So an enterprise user can view the images and the report. And if the risk is queryable, it can grab it from there. Now, I've added one other piece here of EPR integration. There are a lot of EPR systems out there, and what if we want to link up our PACS to that vendor's EPR system? We can send a notification that when the images arrive into our system, we'll send them off to that EPR, and that EPR can turn on a little flag that maybe shows a little image so that when that particular user wants to see the images from the enterprise level, it can click on that button, and that button will make a query to the web server, and the web server will produce the images, and they can see that. And that enterprise user doesn't have to be within the confines of the hospital. That's basically a web-type application in most cases where they can be at their home or anywhere that system's accessible. Okay, so that was a quickie going through the workflow in the department, and that'll help make sense when Steve does his talk in a moment. So that was the simple case. That was the single department and how things operate in a single department. Now what if we have a collection of those single departments? How do we start to bring on the back end into an enterprise PACS all these images that are occurring at different locations with a patient that might have been seen at multiple sites? They might have been up on vacation in Huntsville and need to get those images accessible locally so they don't have to redo that exam. That's where a lot of the cost comes in. When they don't have prior images available or prior information available, they have to actually redo those exams, costing us lots of money. I mentioned before, PACS is not a departmental solution. It is an enterprise solution because the users who are inputting and receiving the outputs are typically other departments, specialties, or in the enterprise. Now, I mentioned earlier that radiology is really pushing the envelope of innovation within the hospital. One of the areas they're pushing hard on is for PACS vendors to implement across regions. And that has created a number of issues, again, coming back to that master patient index. Because the master patient index is really IT/the HIS level responsibility. It's not a downstream radiology responsibility. Radiology needs to use that number so that it can properly manage its information, but it should not be the creator of that information. However, to implement an MPI, as I discussed earlier, is not an easy task, and that's why we're faced with this problem right now where MPIs don't exist, yet the vendors are being pushed to solve these kind of problems. There's a number of projects in Canada, one in Nova Scotia, Northern Ontario, and even out west, where we're starting to utilize the health card number as that natural MPI number. And I know some of you are thinking, well, the health card number is not a perfect number either because, well, what about newborns? They don't have one. What about the natives? What about RCMP? There are exceptions to everything, and they need to be dealt with. For instance, in Nova Scotia, they've gone to the Ministry of Health and mentioned this problem to the ministry, and the ministry has now come and said that for every newborn, within 24 hours, we'll guarantee you a number. So that solved a huge problem because now the percentage of those with a health card number has just gone up to whatever, 90-some-odd%. And now that number becomes more of a usable number that can link the various patient IDs that you may have at multiple facilities together. Then there's a whole issue of fraud and reuse of numbers, and, well, every numbering scheme may have its own advantages and disadvantages. Okay. At a very high level, I really don't want to spend a lot of time on this because then we start getting into sample configurations, and I just want to logically make reference to how some of these systems may be set up. And today, if we take Cambridge, KW, and St. Mary's here and provide an enterprise system, on the front end, each of these are managed independently. So on the front end, each hospital is still going to operate independently, operate as they always have, because on the back end, it's about access. It's not about, let's just merge all this regional information into one big pot, stir it up, and hope it turns out right, because it's not. So it's all about managing logically the data, manage it separately, and then provide linkages, or cross-referencing I call it, on the back end so that now we can link in using the health card number maybe and pull all this information together. Now, tying back into the electronic health record, how do we move forward? Do we just say, yeah, tomorrow I want an electronic health record, let's go? No, it's not that easy, of course, and the electronic health record is like taming the elephant. It's huge, so we need to chew off small pieces at a time. And one of the ways that we are trying to do that is by taking the areas that we have the expertise, radiology, cardiology, and starting to push that up and creating that end-to-end workflow so that at least we can start to get the ball rolling. And then we'll move into labs, add lab reports, go into pharmacy, start reducing some of the drugs that are being generated and providing more efficient workflow. So the step-by-step strategy allows us then to move along these other ologies. It was mentioned earlier about ophthalmology and in labs and pathology. There are lots of areas where imaging is being used, but we need to understand how the workflows work in those departments. In a lot of cases, they're manual. So when you introduce a workflow, radiology is great because it has its own radiology information system. When you go into ophthalmology, for instance, it's a total manual process. Even in pathology, there is no information system. So, okay, now what do? You need an information system in order to generate the workflow. You need to build all that in, and that's a lot of work. So that's why it's so slow in trying to bring all this information together. And a lot of cases where it is being done are single vendors who tend to supply all these solutions, and they've got control of all that data. But if you don't have control of the data, it's much harder to implement. So, in summary, an effective PACS solution is highly dependent upon the complete integration with other systems. An effective EHR strategy is also dependent upon this, and you need the critical data elements available in order to properly make use of an electronic patient or electronic health record in a patient-centric manner. And you've got to link all the stakeholders. And there's political barriers to that. There's lots of different barriers to that in trying to make that happen. But we need to start somewhere. We need to start moving forward in some of those aspects. Each clinical department should continue to operate somewhat independently, but in the context of something much larger, not as a complete island of data. And there are challenges in doing that. I use one example in ophthalmology, but even in cardiology, there is no information system. Cardiology is really broken up into multiple labs, hemo, echo, cath labs, all operate independent of each other. The lack of standards, or even the lack of support for standards that already exist is one of the other areas that needs to improve. And really just progressing in a step-by-step manner is the best way to move forward. It's kind of like you just chew off or attack one area that you can and start moving forward, and seeing how just distributing that data throughout the enterprise really gets the ball rolling. But then, of course, the people at that end, well, what about lab results? What about this? What about that? We've got to continue to provide the data so that it's usable, and they don't just say, well, I can only get this little bit of information. I'm not going to use the system because I can't get this or this or this. And a master patient index really is a cornerstone to making that happen.